Hi, thank you for tuning in to learn more about the science driving the platelet analyzer from Stasys Medical. My name is Matt Sobo and I'm from Diapharma. Please visit our website at www.diapharma.com. To get in touch with us, please send an email at info@diapharma.com and we will answer any questions you may have. So, what is hemostasis? It is the balanced interplay of forces that act to keep blood within a damaged blood vessel. It's comprised of three non-sequential phases: the vascular spasm, which is a vasoconstrictive force of the blood vessels in the area of the wound, and it slows the flow of blood past the wound to increase the chances of platelets and coagulation factors bind to their receptors and substrates in the area. Primary hemostasis sees the formation of a temporary platelet fibrin plug, and it reduces and sometimes eliminates blood loss and acts as a scaffold for secondary hemostasis. The normal wear and tear of your blood vessels you have on a day-to-day basis will be repaired exclusively by this mechanism. Secondary hemostasis is the formation of the stable fibrin polymer mesh, and it is used to eliminate blood loss entirely and seal the damaged walls. When I say these mechanisms are non-sequential, I mean they occur at the same time. Coagulation, secondary hemostasis, begins while primary hemostasis and the platelet plug is still forming. Vascular constriction occurs throughout the entire process. So, injury occurs, disrupting the blood vessels and exposing extracellular collagen to the vasculature. Von Willebrand factor, which is constitutively expressed by the endothelial cells, binds to the exposed collagen. Von Willebrand factor is able to form large multimers, which help to catch passing platelets on their receptor and bring them to the basal membrane, where they adhere to the exposed collagen on their collagen receptors, GP1A, 2A, GP6, and CD36. Once bound to the collagen, the platelet mobilizes calcium ions, activates GP2B3A receptors, it changes its shape to include lots of pseudopods and filopodia to maximize its surface area, and secretes granules. Among the molecules secreted with these granules are ADP and thromboxane A2. Now, ADP will attract to and bind to P2Y1 and P212 receptors on additional platelets flowing past. Thromboxane A2 will bind to the TP receptors on additional platelets and assist with their aggregation. Either of these will lead to the activation of the additional platelet, mobilizing calcium, degranulating the platelet, and activating GP2B3A receptors. Next, fibrinogen will bind to these GP2B3A receptors on multiple platelets, anchoring them together to form a platelet plug. Next, actinomyosin on the filopodia contracts on the fibrin fibers in a hand-over-hand mechanism, shortening the gap between the platelets. This compresses the clot against the tear, allowing blood to flow past, and also making a tighter bind, making it less likely that blood will flow out of the wound. Now, as one can imagine, there are various disorders of primary hemostasis. Some will lead to excessive blood loss, especially during trauma, surgery, menorrhagia, or childbirth. These can be caused by defective platelets or not having enough platelets, a term is thrombocytopenia. On the other end of the spectrum, you can have improper clot formation, especially those that form in the coronary or cerebral arteries. These will lead to myocardial infarction or heart attack or ischemic stroke. Now, the microfluidic cartridge and benchtop reader from Stasys Medical enables the point-of-care assessment of primary hemostasis in a method that is direct and that platelet function is measured without the need for exogenous agonists to be added, either ADP or arachidonic acid or others that are required in many other assays. This test is rapid. There's a 5-minute turnaround time from the start of the test. The results are accurate. The contractile forces are quantitative and measured in the SI units of newtons, and the data are relevant. Hemorrhage and clotting risk assessment are both based on physiological activation of platelets. As I mentioned, the addition of agonist is not required. And it's set up as a collagen-coated array of staggered sets of blocks and posts to measure the platelet function. So, how does this system work? Well, a small volume of native or anticoagulated blood is pumped through the system at the inlet, it flows over the sensor array, and then it flows out the outlet. Shear forces are generated at the blocks and posts, mimicking what is seen in the damaged vasculature. These shear forces, combined with the collagen, stimulate platelet adhesion. As time progresses, these adhered platelets activate and attract additional platelets to aggregate both to the block and post as well as to the previously established platelets. As the platelets aggregate, they begin to exert contractile forces on the fibrin fibers, which will pull the post towards the block, and this can be seen here as a shift in the fluorescence signal. Here we have an image of a block and post set before reaction with platelets, and one that platelets have aggregated and pulled the post towards the block. Primary data output are forces, which are measured in newtons and clot size. This can be seen using the platelet inhibitor MSP, which is a metabolic product of clopidogrel interfering with ADP signaling. A loss of both clot size and the forces generated by the platelets can be seen with increasing concentrations of the drug. From these data, additional parameters can be derived, for example, maximal forces generated and the time to activation, as well as how quickly these forces are generated. Dynamics of clot growth, including its stability, durability, and rate breakdown, can also be determined. Patterns can also be seen when merging these two data onto a single plot of forces and clot size. The example shown here, a subject suffering a significant blood loss shows a smaller clot size than a healthy counterpart while having similar forces generated from the platelets. However, a severely injured subject, both the clot size and the forces generated are inhibited. And this speaks to the loss of hemostatic functionality seen commonly during severe trauma. Tracks such as this could indicate the need for a platelet transfusion to prevent exsanguination. The system utilizes machine learning to analyze changes in the output over time using a multi-factor model of the parameters discussed previously, in addition to the intensity and location of the fluorescent pixels corresponding to the block and post to determine platelet functionality. In the example on this slide, high platelet functionality indicates the research subject would likely not need a blood transfusion. While there are undoubtedly many possible uses for this technology, some more obvious uses are transfusion studies, as discussed on the previous slide, testing of platelet potency, both for donated blood as well as manufactured platelets, as well as studying the kinetics of various anti-platelet therapeutics and primary hemostatic disorders. Another interesting use would be in studying complications that arise due to various infections. As we are all aware, many bacterial and viral infections seem to lead to hemostatic defects, even if the agent itself does not appear to interface with that system. I want to thank you for tuning into this presentation on Stasys Medical and the science behind their technology. If you have any questions, please do not hesitate to reach out to any of us here at Diapharma by emailing us at info@diapharma.com. Also, please visit our website at www.diapharma.com for more information to see a full listing of what we have available. Again, thank you and have a good day.